Vai me arremessar.
Kama alifanya urudi pale pale. Hatuharibu chochote. Hapo maandishi madogo lakini kisha presentation ni wataona. Sababu sasa hivi kupanda kwenye meza tena itakuwa sio.
So those data do result of
Good afternoon once again. Now we are back to our main session of our keynote address. I would like to welcome the Acting Director of Research Liberty RC, Dr. Naya, to come and welcome the keynote presenter. Karibu sana.
Good afternoon, everyone. Good afternoon, everyone. Yeah, you're live. Yes, sorry, I don't want to take more time because of the lost time in between. Just a few introductions to introduce our own Dr. Doreen Kamori. You can see her biography in page 19 in the shared compendium of our symposium for today. So Dr. Doreen is our senior lecturer and researcher at the Department of Microbiology and Immunology, Muhimbili University of Health and Allied Sciences at MUHAS. And she's heading the section of Molecular Laboratory, Department of Microbiology, Immunology here at our university, MUHAS. She's also an adjunct faculty member, collaborating unit for Infection Joint Research Center for Human Retrovirus Infection at the Kumamoto University in Japan. She has been involved in several teaching and research activities at MUHAS, and she's currently mentoring and supervising several other researchers, including more than 30 undergraduate and postgraduate students, but also 2 PhDs which are ongoing. She provides her mentorship to residents enrolled in Tanzanian field of epidemiology and laboratory training programs, who are involved in several research activities, surveillance systems, and outbreak investigation. For more info on her biography, please visit the page 19 of the compendium. But to date, Doreen has published 40 publications in peer-reviewed journals and has presented on various occasions at several local and international conferences, such as International AIDS Society, Conference of retroviruses and opportunistic infections, Keystone Symposium for HIV vaccines, annual meetings in Japan Society of Virology, AIDS Society of Japan, Kumamoto AIDS Seminars, MUHAS Scientific Conference, and today we are happy and glad to host Dr. Doreen Kamori to be with us as keynote speaker for our 11th MUHAS-wide symposium. Welcome, Dr. Doreen Kamori.
Dear guest of honor, Acting Vice Chancellor of MUHAS, Deputy Vice Chancellor PFA, invited guests, representatives from Ministry of Health, MUHAS community, students at MUHAS, ladies and gentlemen, good afternoon. Before I proceed, I would like to express appreciation to the management of MUHAS and the organizing committee of this symposium for appointing me today to give this special keynote presentation on HIV drug resistance in Tanzania. I really feel privileged and honored to give this talk today. So thank you very much. So my talk will be focused on 6 main areas. I will give a background information on the current status of HIV epidemic globally, as well as in Tanzania. Then we'll talk on the drivers of HIV drug resistance. We'll also see the trends of HIV drug resistance in Tanzania. Then we'll also talk about the emerging resistance to the default first-line antiretroviral drug, which is dolutegravir. We also look on the threats to HIV treatment and care program in Tanzania. And lastly, we'll talk on the strategic initiatives. What should we do to control this burden of HIV drug resistance in Tanzania? So according to the UNAIDS report on global HIV epidemic, by the year 2023, it is estimated that at least 39 million people are currently living with HIV. 1.3 million people have acquired HIV, and at least 630,000 people have died due to HIV-related causes. So looking at these numbers, we see that HIV is still a big problem globally. And on top of that, we have a number of things, targets that we need to achieve in order to control the burden of HIV drug resistance in Tanzania. So one of the targets is the 395 UNAIDS target goals, which requires that 90% of people living with HIV should know their status, and 90% of those who know their status should be initiated to treatment, and 95% of them should acquire viral suppression, meaning that they should have undetectable HIV viruses. So this is one of the targets. However, we also have the WHO timeline, which is the 40-year timeline that we have. And this includes the time when the first virus was isolated in the year 1983 to 2030, which is the target to end AIDS. So looking at our situation now, we are in 2024. So we are actually just 6 years away from the target. So it means that if we are to meet this target, we need to be more proactive, more vigilant, and more aggressive in making sure that we improve the quality of care and treatment among people living with HIV in Tanzania, as well as globally. So HIV remains a public health concern, especially in sub-Saharan Africa, where it is estimated that at least 70% of people living with HIV globally, they are from the sub-Saharan African regions. And HIV is associated with morbidity and mortality, especially in sub-Saharan Africa. In the context of our Tanzanian population, the prevalence of HIV is estimated to be 4.5 among adults in Tanzania mainland, which corresponds to 1.5 adults living with HIV in Tanzania. However, we see that there is variation of distribution of HIV prevalence across regions. There are some regions with in the southern highlands of Tanzania, namely Njombe, Iringa, and Mbeya, which have higher HIV prevalences compared to the other remaining regions. In recent decades, major global efforts have been mounted to address the HIV epidemic. And despite the challenges we know so far, we see that there's a significant progress that has been made in addressing the HIV epidemic. We can appreciate that over the course of time, there's an increase in number of people receiving antiretroviral therapy globally, and this corresponds to the decline in number of AIDS-related deaths globally. And it also corresponds to the decline in number of HIV new infection globally. So we still see a similar global trend in Tanzania, whereby we see that there is an increase in number of people living with HIV on antiretroviral therapy. When you compare the data as early as in 2000 and more recent in 2023, we can see a remarkable shift in increase in number of people receiving antiretroviral therapy in Tanzania. And currently our program data also show us that the number of infections of HIV are going down, as well as the number of HIV-related deaths are declining. So this is actually in response to the WHO timeline, and Tanzania has been doing a lot for the past 20 years, and the burden of HIV generally has declined, with now we are having 60,000 new infections per year. And this decline is achieved through multi-sectoral approaches that are done by the government of the Republic of Tanzania, implementing partners, donors, and other stakeholders. It is through these approaches that's why we see the burden of HIV epidemic is declining significantly in Tanzania. There are several sectoral approaches that have been implemented in Tanzania. These include increased efforts in early HIV detection, increased effort in HIV treatment monitoring, adherence to antiretroviral therapy, retention to care, rollout of HIV pre-exposure prophylaxis, PrEP, in HIV key populations, such as female sexual workers, and scale up of antiretroviral therapy, which is the highlight of these efforts. So antiretroviral therapy was first introduced in Tanzania in 2004. And currently we have a number of antiretroviral agents, such as the NRTIs, NRTI, which is the backbone antiretroviral agent. We have protease inhibitors, And currently, since 2019, we have the integrase transfer inhibitor dolutegravir as the first line agent. So this drug is known to be a very good drug because it has high potency, it is tolerable, and it is known to have low genetic barrier to resistance. But apart from these agents, there are also other antiretroviral drugs such as fusion inhibitors and capsid inhibitors, which have been approved for use in other developed countries, but yet to be introduced in our country. So Tanzania being in a resource-limited setting is somehow like a disadvantage to us because we have limited option of antiretroviral therapy. So right now, our first line agents are DTG-based, which are easily accessible. And for clients who are failing on the first line ART, they are normally switched to second line ART, which are PI-based. And for those who are failing in second line, they are switched to the third line ART, where the disadvantage of these agents is that there are fewer options. And most of these drugs in the third line are associated with multiple side effects, and they are very costful. And more alarming is that currently in a clinical setting, we see that there's an increase in turnover of people to be switched to third line antiretroviral therapy because of treatment failure. So it means that we really need to be very careful in monitoring people living with HIV on first line and second line antiretroviral therapy so as to prevent the risk of them experiencing treatment failure and therefore succumbing to the third line antiretroviral therapy. So since the introduction of dolutegravir, we can see that the drug is doing very well in terms of viral suppression. So when we compare the data on the from the Tanzania HIV Impact Survey in 2016 to 17 versus the data in 2022 to 2023, we can appreciate that there is remarkable improvement in terms of viral suppression, whereby initially the viral suppression was estimated at 87% before DTG, and later on, after introduction of dolutegravir in the country, we see that the viral suppression has remarkably increased to 94%. So with the increase in uptake of antiretroviral therapy, studies continue to show that the number of people living with HIV is also increasing in terms of those who are experiencing treatment failure on first line and second line ART regimens. There are a number of studies that have been done across the two subpopulations, and evidence so far shows us that there is an increase in prevalence rate of biological failure among individuals who are on first line. You can see that in 2016, we had 14.9%, and later on in recent years, biological failure has been detected as high as 32%. And in studies that have investigated treatment failure or biological failure in individuals who are on second line, they have also reported a high prevalence of up to 13% of individuals failing in second line. So one of the major factors that contributes to the treatment failure among people living with HIV is HIV drug resistance. So drug resistance is the major contributor in this population. And resistance is caused normally by the changes or mutations in the virus genome that tend to affect the ability of antiretroviral drugs to block HIV replication in the various steps of the viral replication cycle. And currently, existing data inform us that all available antiretroviral drugs, including the newer ones, they are potentially at risk either to be partially or fully inactive because of emerging HIV drug resistant strains. So HIV drug resistance can be categorized into two major groups. We have the pre-treatment HIV drug resistance, PDR, and acquired HIV drug resistance, which is ADR. So PDR normally occurs when one is infected with, for the first time, with a virus that already has existing HIV drug resistance mutation. But also it can occur in a situation when one has been exposed to previous antiretroviral therapy, for example, in prevention of mother-to-child transmission of HIV, and also among HIV key population who are using PrEP. While for the acquired HIV drug resistance, this normally occurs following the use of antiretroviral drugs over the course of time. So to date, there are several drivers that have been documented to cause or accelerate emergence of HIV drug resistance. This includes patient-related factors, such as poor adherence that could be caused by other underlying factors, such as stigma, drug fatigue, drug toxicity, mental health issues, as well as other socio-economic issues. These are shown that they may drive emergence of HIV drug resistance. We also have the programmatic factors, and this includes suboptimal quality of services, such as issues of drug stockout, suboptimal retention to care, suboptimal viral load monitoring. So these factors, if they are not well addressed in an ART program, they may subject people living with HIV to be at risk of getting HIV drug resistance. We also have other factors such as drug-related factors, including the low genetic barrier to resistance, such as observed in NNRTIs. We have issues of drug-to-drug interactions, suboptimal regimen dosage, especially this is seen in pediatric population. And number 4 is the viral factors, which include the circulating subtypes. There's strong evidence which shows that the various HIV subtypes may have differential selection pressure that may lead one to be more at risk to acquire HIV drug resistance compared to others, such as subtype C, which is among the predominating HIV subtypes in our country. So what has Tanzania done so far with regard to HIV drug resistance? We have some efforts done by the program, and then we also have the other aspect on research. So in the side of program, there are a number of initiatives that have been done. These include facility-based surveys that have been conducted in the past to estimate the burden of HIV drug resistance among adults and children, and also among pregnant women. But also we have the scale up of HIV drug resistance testing in the country. We have the national lab and other designated zonal and a few of referral labs, referral regional labs that are involved in HIV drug resistance testing. We also have initiation of the genotypic antiretroviral resistance test, GATT, which is in place, which helps to monitor individuals who are on second line who are experiencing virological failure. We have the introduction of cyclical acquired drug resistance, CADA. But in terms of research, there are a number of cross-sectional studies that have been conducted in Tanzania to estimate the burden of HIV drug resistance. Some of these studies have been conducted in single centers and a few centers in some exceptions. But the limitation here is that we have very few studies that have been conducted after transitioning to dolutegravir. So we have very few information on that. So this is the landscape which basically shows the trend of HIV drug resistance studies conducted in Tanzania. We can see that there are some studies that have been conducted as early as in 2004 when we rolled out antiretroviral therapy to match recent years over the course of time. So the next thing that we need to think about or to find out from these studies that have been conducted, I will focus more on the studies that are conducted before transitioning to DTG. So what we can deduce here is that, for instance, in terms of pre-treatment drug resistance, so we can see that from local studies that have been conducted in Tanzania, already we had substantial number of individuals experiencing virological failure with pre-treatment HIV drug resistance. And most of these studies have reported a prevalence that has crossed the WHO threshold of 10%. Whereas for the case of acquired drug resistance, we can see that the burden is actually more high. There are studies that have reported a high prevalence as high as more than 90% among treatment-experienced individuals. So these studies really inform us that the burden of HIV drug resistance in Tanzania is very high. So recent data since the rollout of DTG so far tends to provide good indication that DTG can steer sub-Saharan African region towards achieving the third 95 UNAID targets for HIV cascade of HIV care. However, currently we see that there are some observational and country-generated survey data that tend to indicate that the levels of HIV drug resistance to dolutegravir is exceeding the levels in clinical trials that were performed in developed countries and other settings. So national surveys elsewhere have reported that the level of resistance to dolutegravir ranges from 3.9, for example, in Uganda, 8.6 in Malawi, and even has reached as high as 19.6% in Mozambique. And the key thing that we need to capture here is that this resistance has actually been reported in individuals who were transitioned to DTG while having high viral load. And more alarming, we see that DTG resistance is not only detected among people who are treatment experienced, but now more evidence is coming among even pre-treatment or treatment naive individuals. For example, Haiti, they have reported prevalence of DTG resistance among infants. So it is becoming clear that sub-Saharan African settings may expose dolutegravir to factors threatening its effectiveness and hence promote rapid selection of resistance mutations that were not previously observed or encountered in other regions. So we can see here like a number of studies. Some are cross-sectional studies, and we have also some of the paper-funded DTG resistance surveys. They all report on the prevalence of DTG resistance. For example, you can see Cameroon has reported DTG resistance as high as 12.8%. And of course, we have these national surveys in countries such as Mozambique, where the DTG resistance has been reported to be 19.6. So this information is actually telling us that although we see DTG is performing well in terms of viral suppression, but this regimen is in continuous impending danger of being resisted by people living with HIV on antiretroviral therapy. So previously, our group, we had tried to analyze dolutegravir resistance before the rollout of DTG. So this study was actually conducted in 2017 using Tanzanian population. And by then, we could not detect any major dolutegravir resistance within Tanzanian population. But instead, we had only detected accessory integrase drug resistance mutations at a very low rate of 1.8%. However, later on, post DTG rollout or post DTG introduction in the country, we conducted national surveillance with the Ministry of Health to assess the burden of HIV drug resistance, including dolutegravir. So what we observed from this national survey is that 5.8% of individuals who were experiencing virological failure or having high viremia had dolutegravir resistance. And mind you, this survey was actually done just 18 months after the rollout of dolutegravir in the country. And more recent, other colleagues at MUHAS, they also conducted a cross-sectional study looking at the dolutegravir resistance, investigating the burden in 6 clinics in Dar es Salaam. And what they observed from this study is that the dolutegravir resistance was high, and it was actually higher compared to the findings we observed in the national surveillance. So they had detected the prevalence of DTG resistance at 10%. So this information tells us that, again, that DTG is a good drug and it has a potential, but it is under continuous threat of failing within our ART program if we do not become more proactive in making sure that we reduce this risk. So there are various factors or issues that currently they pose a threat to our ART program. These factors, if they are not well dealt, may lead to increase in DTG resistance, eventually increase in HIV non-suppression and treatment failure among Tanzanian population. So we have factors that are related to the program. Here we are talking about DTG transition strategy. As we know, when we were transitioning to DTG, all individuals who were on antiretroviral therapy were considered to be eligible to be transitioned to DTG, regardless whether they are virally suppressed or not. And then we have issues on HIV viral monitoring and coverage. This is an area whereby it also poses a threat to the success of our ART program in Tanzania. We have HVL results turnaround time, HIV early diagnosis, suboptimal ART adherence, suboptimal rotation to care, and the PrEP scale-up. We also have other host factors that pose as a threat. This includes high-risk behavior, especially in HIV key populations, host genotypes, and we also have the viral factors such as the circulating HIV subtypes and the recombinants that may pose a threat to the success of our ART program. So in order to prevent and reduce HIV drug resistance in Tanzania, it is important to be strategic. It is important to come up with strategic initiatives that will help us to reduce the burden of HIV drug resistance in Tanzania. And these strategic initiatives, they can be realized through stakeholders, research and innovation, as well as through our national ART program. So in the aspect of ART program, there are a number of areas where we can be more proactive and come up with strategies that can help us now to either prevent or reduce the burden of HIV drug resistance in Tanzania, especially to DTG. These include early warning indicators for HIV drug resistance. This is one area where we need to have some strategic initiatives, which may include active monitoring of early warning indicators, which will help us to measure the performance of our ART program and therefore preventing the emergence of HIV drug resistance. We also need to strengthen specific aspects of ART program delivery at site level so as to minimize preventable HIV drug resistance and promote long-term efficacy and durability of the available first-line and second-line antiretroviral regimens in the country. Another area where we need to be strategic is on the transitioning strategies and policies. It's very important, I think, as a country to develop policies for rolling out newer ART regimens so that we become more prepared. But also, there's a need to have the National Action Plan on HIV drug resistance in Tanzania. Another area where we need to have some strategic initiatives is on HIV viral load monitoring. It's very important to work harder or strive to increase HIV viral load coverage in terms of expanding the number of facilities with the capacity of testing or of monitoring HIV viral load. And also we need to think of employing more point of care testing technologies for monitoring viral load. We need to strengthen HVL monitoring by also improving turnaround time, because this will help us to timely detect virological failure. But also we need to improve proper sample collection, storage, issues on transportation to prevent false viral suppression or delay in detection of virological failure due to sample rejection and other factors. ART adherence is also another area where we need to be strategic. Here we need to think of developing strategies to promote antiretroviral adherence among people living with HIV, monitor ART adherence aggressively, and promote differentiated service delivery that is client-centered. Another important area where we need to be strategic is on HIV drug resistance monitoring. It is important as a country to conduct routine HIV drug resistance monitoring, scale up HIV drug resistance testing facilities, decentralize and strengthen multidisciplinary teams, MDTs, for proper switching of ART regimens between clients. We also have to think of doing or conducting routine PDR and ADR resistance surveillances. And also as a country, we need to think of rolling out to the use of WHO recommended laboratory-based drug resistance surveillance approaches, which requires us to use remnant samples of testing HIV viral load to estimate HIV drug resistance. Another area where we need to be strategic is retention to care. There's a need to come up with interventions to address issues of stigma that affect the retention to care of people living with HIV. But also we need to come with robust systems for loss to follow up. Other areas where we need to come with strategic initiatives include data reporting systems. There's a need to strengthen our data reporting systems so that to monitor and report quality of care indicators more effectively. And we also need through this to enhance active engagement of ART clinics and programs in the use of indicator data to develop locally appropriate and sustainable solutions. Another area is on pre-exposure prophylaxis. As a country, we have scaled up PrEP among high-risk populations in Tanzania. But it's very important as we are scaling up PrEP, we need also to monitor PrEP adherence and conduct surveillances for HIV drug resistance among people on PrEP who had breakthrough infections of HIV, because evidence in other settings has shown that people who have been on PrEP and when they have breakout infections, there is a high risk of getting HIV drug resistance as well. But also as a country, we need also to think about long-acting agents for PrEP, such as cabotegravir. These have been shown to be effective in other settings. So we need to think of these things. In terms of research and innovation, there are a number of things that we need to do as researchers and stakeholders. We need to look on predictors of HIV drug resistance. We need to look at factors such as host genotypes, viral characteristics, psychosocial factors that have been shown to increase the risk of HIV drug resistance in most settings. We also need to look on the predisposing mutations or polymorphisms that have been reported to occur outside the POL gene that are known to accelerate acquired HIV drug resistance. I think this is one area which is understudied in our setting. But also we need to look at the phenotypic drug susceptibility testing for ART. It may seem ambitious, but I think it's one area where we need to do something in terms of research so that we may get data that will inform policy in the context of our Tanzanian population. I also think that it's very important to evaluate primary and secondary resistance either to current existing ART agents or newer ART agents that may be likely to be introduced in the country. And as an initiative, currently our group, we are working on the new ART agent, capsid inhibitors, which is recently approved, lenacapavir. So here our interest has been to look at the drug properties, such as the binding sites, but also we are interested to look on the resistance towards this drug. And what we noticed from this initial work we have done is that although this is a new agent, but we also see there's some evidence of resistance towards lenacapavir. And we also noticed that there is variation on the binding sites of this agent. So the key issue here is that most of antiretroviral agents, as we all know, they are developed in Western countries, in developed countries, and they may be tested in populations that are genetically different, and there are multiple factors that are different from our settings. So the drugs may be proven to be effective in those settings, but there's a risk that the outcome may not be the same in our setting. So this is a call that we need to be more proactive in doing research so as to assess feasibility of these newer antiretroviral agents. So as I am winding, I felt that my entire presentation could actually be concluded by a message that was shared by Dr. Meg, who is the director of WHO Department of Global HIV, Hepatitis and STI programs, where she said that the worrying evidence of resistance in individuals with unsuppressed viral load, despite dolutegravir treatment, underscores the necessity for increased vigilance and intensified efforts to optimize the quality of HIV care delivery. Standardized surveillance of HIV drug resistance is essential for effectively preventing, monitoring, and responding to these challenges. So today we as stakeholders and researchers, we are all accountable to be more vigilant, more proactive in coming up with strategic initiatives to control the burden of HIV drug resistance in Tanzania. I would like to thank you all for listening.
Thank you so much, Dr. Doreen, for that. Without wasting much time, I would like to welcome the chairperson of the panel discussion, Professor Lamuya, will come and introduce the people who, the panelists for this session, and continue with the session. Karibu, Professor.
The guest of honor, Professor Said Aboud, one of my brilliant students, the Deputy Vice Chancellors here present, other members of the university management, symposium participants, ladies and gentlemen, good afternoon. The subject today is a subject of great interest all over the world. Antimicrobial resistance is a growing subject. You know, we human beings are fighting for survival by using various strategies, including trying to modify the environment, trying to fight microorganisms which affect us in one way or another, okay? As we do that, the microbes are also developing strategies for survival. And this is where we encounter problems because viruses develop antiviral drug resistance, bacteria develop resistance against antibiotics, fungi develop antifungal drug resistance, and even protozoa are developing antiprotozoal drug resistance. So it is a battle that is wide. Our focus today is on antiretroviral drug resistance and specifically against HIV, which is one of the serious epidemics of our time. And our great concern is that this strategy that has proven very, very beneficial for the survival of people living with HIV and AIDS is encountering very serious problems, and hence the importance of the session today. We shall have 4 panelists who will contribute to our discussion today. Let me call them, and as I call, they should come to the front and sit, starting with Dr. Wana Maokola, who is the head of Strategic Information Unit, National AIDS, Sexually Transmitted Infections, and Hepatitis Control Program. Welcome, please. Yes. Then we have Dr. Joan Rugemalila, who is a physician at Muhimbili National Hospital, but also a member of the National HIV Drug Resistance Technical Working Group in Tanzania. Then Professor Rafael Sangeda, who is a professor of pharmaceutical microbiology at MUHAS. And then Professor Takamasa Ueno, a professor from Kumamoto University, Japan. The scientific and the professional accomplishments of these panelists is summarized in the bios which appear in the compendium. But I'm requesting, with the permission of the other panelists, to allow me to kind of speak for one of the panelists, because you know our tradition is when a guest comes home, he or she is given a special kind of treatment. And I'm making reference to Professor Takamasa Ueno, who is a professor of microbiology and immunology at Kumamoto University. And this professor also is associated with the Joint Research Center for Human Retrovirus Infection in Japan as a director. And important for us, he's a honorary professor of microbiology and immunology at our institution. Now, Professor Ueno is someone who has done a lot in HIV science in general, and specifically for HIV drug resistance. He was working at the National Institute for Health in the USA, together with Dr. Misuya, who founded various antiretroviral drugs, including zidovudin, DDI, and darunavir. So at that time, Professor Ueno was also working on HIV drug resistance, including the emergence of HIV variants, resistance to multiple DDO nucleosides from patients receiving AZT and the DDI and DDC combination therapy. That was about 30 years ago. Ladies and gentlemen, very important for us also is the contribution of Professor Ueno in capacity building in our institution. Since we started our collaboration in 2016, it is on record that he has mentored 10 PhD students, and there are 3 other PhD students who are still ongoing under his mentorship. So in a span of 8 years, that is the contribution. Now, panelists, I'm going to ask you some questions, and I will request each of you to respond, taking into consideration the time constraint that we have, at least less than 15 minutes. That will be okay. There will be a timekeeper helping me. And we hope that after responding to those questions, we shall have adequate information that will generate a very good discussion amongst us. Let me start with our representative from the Ministry of Health, Dr. Wana Maokola. The Ministry of Health is very, very key in all HIV-related activities in the country. With regard to HIV drug resistance, could you please tell us what interventions the government through the Ministry of Health has done and intends to implement in order to control HIV drug resistance in the country? And secondly, I would like you to also brief us on the key gaps and the challenges towards control of HIV drug resistance in the country, and any experience that you have gained that will be of interest to us. Please.
Good afternoon. Thank you very much, Professor Lyamuya, for inviting me to be the first speaker. And thank you very much for the organizers to consider MOH representative to be one of the speakers this afternoon. And probably I should make clear that in the book, there's my boss, who is Dr. Prosper Njau. So I'm representing him. I'm not Dr. Prosper, just to make everybody aware of that. So with regards to what you have asked me to talk to the audience regarding HIV drug resistance interventions within MOH, I'm very glad that Dr. Doreen actually preempted me and talked almost all what the ministry is doing. So my work is very easy to just complement what she has told us a few minutes ago. And I can classify the interventions into two. First, those which are now being implemented, and secondly, those which are about to be implemented in the future. The first one is, as you know, the role of the ministry is to coordinate HIV within the country. So our main role actually is coordination. So in terms of HIV drug resistance, one of the things we are doing is on policy. So once there's a new policy as stipulated by Dr. Doreen, that there's a new policy, let's say from WHO, it's our duty to adopt it in our context. So that is the main role of the Minister of Health, and make sure that our clinicians and everybody adheres to the guideline. But secondly, on service provision, we insist on adherence, as also stipulated by Dr. Doreen. But another thing is on ART monitoring, which has also been preempted. But I would like to elaborate that what we usually do is we monitor HIV treatment using HVL, which is HIV viral load on regular intervals. And once a person is found to be of a higher threshold, we'll undergo enhanced adherence and counseling. And after that, if there's treatment failure, that person will be switched to another line. And if he's from second to third, we have genotyping. But from first line to second line, we depend on the HIV viral load. Another intervention we are doing as a Ministry of Health is evidence-based. We are doing surveys, periodic surveys to monitor drug resistance, but we are also doing surveillance. We have started to do laboratory-based surveillance, which was also highlighted here by the name of CADRE. That is using remnants of blood collected for HVL, but we are using it for genotyping, which is a bit cheaper rather than doing periodic surveys. Periodic surveys are very expensive. So embarking into laboratory-based surveillance is a bit cheaper and can lead us into having effective ART monitoring. And the second aspect on the future directions, we would like as a ministry to move from periodic surveys, which I said are very expensive, and invest on doing surveillance using blood remnants, which is cheaper. But we have just started the surveillance using blood remnants. One of the things we are struggling is where do we do the genotyping, because the number of laboratories accredited for genotyping are very few. But our wish is to have more laboratory doing the genotyping and expand the service. But the other future endeavor which we would like to go into is currently moving from first line ART to second line. We are using HVL, which is HIV viral load. And we would like to go into doing genotyping, because some studies have shown that some of the clients who were moved from first line to second line didn't actually have mutation, but they have other reasons for not having good treatment outcomes, but yet they were switched. So once we have genotyping for first line to second line, we will do genotyping and know who exactly has a mutation. And if there's other reasons for treatment failure, we will tackle that rather than switching clients blindly. The other thing is the ministry, our wish is to, Doreen talked about transmitted HIV drug resistance. That is, a person gets HIV with the mutation. So if one is started on ART, definitely after 6 months, when we do the HVL, we'll see that the treatment is not working. So our wish is to have everybody doing genotyping before ART initiation. That is the practice in the developing world, but because of our economic constraints, we don't do genotyping at the start, except for the moving from second line to third line. So as a ministry, we would really like to have genotyping conducted to all our clients who are starting ART, so that we may know their sensitivity profiles and start them into the appropriate regimens. So in terms of the key gaps, maybe I can, for the interest of time, I can highlight a very few of them. One is purely on clinical aspects. I think we all know about children, and it's very tricky to treat children. And what we have seen is one of the experience with working with the ministries, our clinicians usually fail to adjust doses for pediatrics. So you see children having suboptimal treatment for HIV and then succumb to drug failure because they've been exposed to suboptimal levels of the drug. So insisting on our clinicians to do those adjustments to our pediatrics would help us prevent HIV drug resistance. The other thing is purely HIV, health system issues. As I said in the beginning, that we would like to have a luxury or have a practice of doing genotyping before ART initiation. But I think one of the things which is holding us is cost. It's very costly to do these tests. So as a Ministry of Health, we are aware of this good practice of doing genotyping prior to ART initiation, and we are working on the possibility of doing that. But the other thing which also would enhance our ART monitoring and prevent HIV drug resistance is to scale up the number of laboratories doing genotyping. And we, in the near future, we will have other laboratories doing. Currently, I think is Temeke, which is dependent for the whole country, but we will have other sites also doing genotyping, so that when we start the practice of doing genotyping for any viremia, or for those who are starting ART, it would be easy to do them in the zones rather than transporting samples to DAR. Just to wind up, I think all the gaps have highlighted result of financial constraint we are facing. So as a country also, I think some of you are aware of the move to have HIV sustainability beyond 2030. We know what has happened since the first response in 2004, the support we had from PEPFAR, Global Fund. So the countries actually, most developing countries, are now thinking of what will happen after 2030. And we are now working on HIV sustainability as a country to finance the response from our own pockets. So this will solve most of what we are now facing in terms of adopting the best practices. So thank you very much, and back to you, moderator.
Thank you very much, Werner. Very well done in terms of time management. Now to you, Joan. Dolutegravir has been mentioned repeatedly, and in the keynote presentation, there's a lot of information that we got, including that it is a promising drug for HIV viral suppression. Now, what is your experience in your clinical practice in the performance of the drug in the care of HIV/AIDS patients?
Okay, thank you very much, Professor Lemuya, and thank you, the organizers and MUHAS as a whole, for giving me an opportunity to be part and parcel of this discussion. So yeah, much as we have heard about all the merits or the benefits of dolutegravir, the experience that we have is more of seeing the significant move from suboptimal viral suppression to high levels, proportions or rates, if we may call it that way, that most people living with HIV in different populations have significantly improved their viral suppression. However, in the experience that I've had in the National Third Line Committee, we have few of the cases we have seen have developed drug resistance to dolutegravir. It was given as a, for the transition that we heard from the keynote speaker, that we transitioned regardless of either suppression or knowing the resistance pattern of these people. So we weren't prepared. And now we had a group of, a subgroup of people living with HIV who had, or who are experiencing a sequential functional monotherapy, meaning that they were on the failing regimen with other classes, the NRTIs or the PIs. Then here we came and just added dolutegravir. So a short-term desire we had was to suppress. Yes, they suppressed, but over time, they rebounded to virological failure, meaning that it was just given to acquire a short-term, suppression. But again, the few who have dolutegravir resistance, some are in serious situations, like meaning that the cases that developed a class of or a pan-INSTI resistance to more than dolutegravir in the class of integrase inhibitors. They had resistance to drugs we have not used, cabotegravir, vitegravir, and the like. And so it has been really difficult for these few cases to choose their subsequent regimen, meaning that the PIs, some of them were not working, but at least 50% of them had susceptibility to PIs. So we had an option. But the few who had no option actually are continuing to be on the failing regimen. So as the speaker, the keynote speaker alluded to, that we need to have close monitoring of drug resistance to dolutegravir, because if it has a picture of cross resistance, it means we are doomed to fail in the near future. Thank you.
So, Joan, what issues should be prioritized by the Ministry of Health in strengthening HIV care and treatment among clients on DTG in order to prevent emergence of DTG resistance?
Thank you, Professor. So, I mean, most of the clients now in the country, I think most of them are in dolutegravir-based regimen. So we kind of advise or give an opinion towards all of people who are using dolutegravir plus the few who are not using dolutegravir-based regimen. So the quality of care is really key, as we have seen in the presentation. And the experience of suboptimal quality of care, something that needs a special eye, especially in specific populations who are at high risk of developing aortic failure. We speak of children, who some of them are orphans taken care by guardians or people or other people in the family. We have also a group of adolescents and young girls whom they really need a special attention in their assessment of ART monitoring, a comprehensive assessment. Adherence is one. These adolescents will know what you want to ask them when they come to the clinic. They know you use a pill count. They will count their pills, come with the ones that you want to hear, that I have how many pills in this month. They will answer your questions because they are already now used to that. So they are heavily treated. They know what you're going to ask them in their adherence assessment. So we need also to revise the assessment tools to cater with what is going on after a long time. We are still using the very same tools of adherence 10 years back, and they are used to them. But the key here is those indirect factors which are not directly like HVL monitoring. Stigma can be one of them. Adherence could be another one, but also monitoring of the side effects of ARVs, interactions as well. These factors will make these people not to take the drugs. So they are indirect causes of adherence actually. And this should be looked into with a special eye, as I mentioned in these groups. But again, also, you introduced us the issue of AMR, and the stewardship is always key. So stewardship, you can hear it in antibacterials, but you can hardly hear it in antivirals, especially HIV now, where we see the alarming rates of drug resistance. So my opinion would be to include HIV-DR in the national policies or national action plans, as it has been mentioned by the keynote speaker, but also education to the public or the community. They need to know it's not only the antibiotics that will develop resistance if they're not well used. The antivirals as well is one of the issues. So health education, the component that can be included in AMR stewardship at facility levels to the community, the scope should be that wide. Thank you, Prof.
Okay, thank you very much. Professor Sangeda, currently there are new promising drugs for HIV treatment, such as long-acting antiretroviral therapies for treatment and also pre-exposure prophylaxis. What are your views on the feasibility and acceptability of such drugs in our country? And what will this mean in terms of HIV drug resistance? Another issue that I want you to respond to is what is the influence of what lessons from the lessons that we have learned from the emerging DTG resistance? What is the path you would recommend for policymakers to follow? either when introducing new antiretroviral therapy agents or transitioning to newer antiretroviral agents in the country. In the course of responding to these two questions, I would also like you to inject influence of ART adherence and stigma on HIV drug resistance in Tanzania. Please.
Thank you so much, Professor Lamuya, the chair, for this particular symposium. And first of all, I want to acknowledge that Professor Lamuya was my PhD supervisor back in 2013. That is 11 years back, where I was working on machine learning algorithms to predict HIV drug resistance. So back then, when you talk about machine learning, artificial intelligence, people look at you like a lost or a lost person. So we appreciate you, Professor. We went a lot through some of these things we're discussing now. And if you ask me, I will start with the last question, which has also been preempted by the keynote speaker. But I will just choose this aspect of adherence and stigma. So if you ask me, how do we prevent HIV drug resistance? I would say in a simple language, but it's actually not that simple, that let's monitor adherence. Nevertheless, if Professor Kileo was here today, he would have said that HIV drug resistance is a wicked problem. So a wicked problem is a problem which is so complex, and it will require solutions that involve a lot of people. Some of the solutions may be very simple. So HIV, we know, will always evolve, will develop mutations because of the quick turnaround of mutations, and finally it will develop as a survival mechanism, it will develop mutations, and some of these under suboptimal dose, they will develop now these drug-resistant mutations. So if you look there, suboptimal adherence is because people do not adhere, people do not take their medications as they are advised by the healthcare workers to do so at the right time, at the right dose. People take a break, people forget, people want to enjoy, for example, they know you cannot take medication with alcohol, they will take a break just to enjoy themselves. They will shy away when there is people are sitting together, like I cannot open my pills in front of you because you will, it will induce another problem, which I want also to emphasize. If we can get rid of these two things, stigma, we also solving the problem of adherence. So stigma starts with all of us. You know, there are a lot of myths. People think that if you're HIV, maybe you can infect others. If you are HIV, you cannot have kids. All these myths, they cause these stigma. So HIV patients will not open up. They will not tell their partners. They will not tell their relatives they are living with this condition, which predisposes them to still the problem of adherence and not taking their medications. So if we can monitor adherence, we can solve a lot of problems. And some of the solutions, maybe I can already go to that, includes what the keynote speaker said, the differentiated service delivery. I think that's one approach which is patient-centered. For example, adherence clubs. You can have adherence clubs where the patients who are a bit stable in terms of their clinical progression, they can come to the club and they can discuss their issues, including some of the adherence issues. So that can be one of the solutions. So adherence is really, in one of the studies that we published with colleagues from KU Leuven in Belgium, we use adaptive, complex adaptive systems, which is a systems map approach to map the problems that can prevent HIV drug resistance. And we tried that in the Dukes urban cohort population. where we observed by sitting with the stakeholders from the National AIDS Control Program was one of them back then, now NASHCOP. And we sit with the stakeholders involved, including the patients. And one of the things that emerged from those discussions that we mapped in the systems map was the adherence issue, workforce overload, because there are so many patients. When I was working at Amana, 200 patients were coming per day. There were only about 5 clinicians. So time for adherence counseling was very limited. So healthcare overload is also part of the problem that leads to adherence issues. Now let me come back to the other questions. For long-acting antiretroviral therapy and pre-exposure prophylaxis. This has also been discussed by the keynote speaker, that we have drugs like the cabotegravir, which is already being tested. So this has been done in HPTN 83, HPTN 84. Some of these trials had to be stopped prematurely because the evidence was very clear that people who were on this treatment by cabotegravir and riliveprin, they were, for example, 9 times more likely. I mean, those who were not were more, like 9 times more likely to develop infection when you're using it for PrEP. So that it was very clear that cabotegravir and riliveprin were very effective. So there's no doubt about those long-acting drugs. They work very well. And it has been proven in the clinical trials already. Of course, there are other ones, like also the keynote speaker presented, lenacapavir. This is also, I think, an injectable. The cabotegravir is also an injectable that you take 1 month, each 1 month, or I think you start with twice, and then you repeat every other month. So that's quite interesting. Imagine if you have that, you're already addressing the issue of adherence, but you're also addressing the issue of stigma, because I don't have to worry about opening my pills. I can just take it, I take a shot and then I forget about it. There is also a drug that is a once a month pill that is also under investigation. It's called Tranavil. So this is also an opportunity that we might think of. So with regard to feasibility, yes, it's feasible because we have infrastructure in Tanzania. We have supply chain logistic. MSD has such a network of supply. We don't have issues of running stockouts. The such supply chain is good. The workforce is there. Training has been done. And of course, it will address the issue of adherence. With regard to acceptability, yes, it will be acceptable. And of course, I've said it will reduce stigma. And but we need to, I think we need to more sensitize the community to avoid the stigma for these kind of regimens to be effective. And indeed, once we are able to control adherence, once we are able to control stigma, once we have, for example, cabotegravir, which is the keynote speaker said has high genetic barrier to HIV drug resistance, then we will delay HIV drug resistance for sure. The question is about the cost. So if you take these current regimens, TLE, TLD, per year, it is estimated that it will cost less than $50. But Dr. Wena can correct me because I'm just reading the literature where he's actually implementing that. It costs less than $50. But when you come to these new regimens, it will cost us about $60 maybe to $120 per year. And I think that's a bit expensive. Nevertheless, the company the VIV Healthcare that is producing cabotegravir has made license agreement with some countries, low and middle income countries, to develop the generic drug. And I hope with these kind of agreements, it will get cheaper and cheaper, and maybe it will be available to countries like ours. But before that happens, I think we just have to pray that resistance remain low. With regard to advising the policymakers, so regarding the switch to dolutegravir, so again, referring to the keynote speaker, it seems we had to, our approach for treatment in Tanzania is based on population-based approach. It's not individualized treatment like it is in other countries. In other developed countries, you genotype every time you want to start the patient on new therapy. So we don't have that. We have population-based. We base on surveillance by WHO, our own surveillance, and we decide. So I'm not blaming Dr. Wena. That is in 2019, everybody was switched to dolutegravir. But what we are saying is maybe an approach should have been taken. Look at the data that she presented. There were about 62% that had resistance to NNRTI, and I think less than 50. So if I were to do that, I would look at that data. But again, we should have done genotyping to decide for everyone that we want to switch them to this particular drug. But looking at that trend, it seems that we could have only switched maybe 40% of the population first. Okay, so that would have saved us some money, or avoiding quick switch of the dolutegravir to second and third line. So when we are rolling out a new regimen, we should think of the possibility of, I know Dr. Wena said, we are looking at the possibility of genotyping everyone, but if that is not possible, then we have to scale up the national surveillance so we know in every region what is the situation, which kind of mutations do we have. And I'm encouraging that we have, as we do that surveillance, we keep a national database. I know we have databases of patients, but of sequences in order to track the kind of mutations that we see over time, because it's very important to keep the aspect of time. So what kind of mutation involved in the first year? So you see, it's only 2019, 2023, it's just a few years, and we already seen 5.8% to 10% in one of the papers we published, also at Dukes, 10%, but of course, you have to be aware when you say 10%, it was only 3 patients out of, so it was 600 patients were monitored, 33 had viral load, high viral load, above 100,000 copies per ml. And then those 33, only 3 had mutations for the dolutegravir, that is 10%. So, but again, for such a short time, to have these kind of mutations, we need to ask ourselves questions. Did these patients sneak in dolutegravir before we started rolling out? How comes it's coming so quickly? Maybe some of our people were buying dolutegravir from Kenya or from Europe, I don't know. We need to find out. So, but otherwise, it might be to do with adherence, which we can easily control. Dr. Jones talked about the different approaches, pill count. They know that you do the pill count, and then they will bring the friends' pills and they bring them. They can even borrow the pills from the other patients. If you talk about self-reported adherence, you ask them, do you take your medications? They'll say yes. Nevertheless, the other approaches like pharmacy refill, which we try to validate in one of our studies, and pharmacy refill can do quite well to detect people who are likely to have adherence issues, and then adherence counseling. So if you ask what kind of things we have to do, then I would say what others said, surveillance, pharmacovigilance to monitor that HIV drug resistance doesn't emerge so quickly. Regulatory frameworks and policies have been mentioned to monitor this emerging resistance, but also we need to invest in research. So I said we need the HIV drug resistance database, but that needs to be monitored by researchers. What are the kind of trends that are emerging? Training to healthcare workers, training to clinicians. I'm not sure how many clinicians, apart from the few in this field, if you ask them, I give you this sequence, HIV sequence, tell me what this mutation entails to the progression of the patient. I don't know how many can do that. And training for the healthcare workers, training for the clinicians, for drug interpretation. My time is up. Thank you very much.
Okay, thank you very much, Professor Sangeda. Now to Ueno Sensei. Based on your research experience, which is quite long, as I mentioned, in the field of HIV, what, in your opinion, do you see as the potential opportunities for HIV drug resistance research in Tanzania, and actually generally in lower and middle income countries? That is one. Two, as an expert in the field of HIV viral evolution and drug resistance, what is your comment on the current public health approach to HIV treatment in low and middle income countries such as Tanzania? To you, Ueno.
Okay, thank you for kind introduction, Professor Lamia, and also thanks for all organizers for giving me such opportunity. So one issue really I'm really glad and surprised is actually Dr. Donnie Kamoli is back to, I think it's 2012 or 13, or she joined to my group. And at that time we are doing a bunch of HIV sequences in accessory region of HIV proteins and looking for like naturally occurring polymorphisms associating with host genetics. And she did a lot and lots of sequencing. And now, 10 years, maybe nearly 10 years later, she is actually a young leader of HIV drug resistance studies in this country as well as in sub-Saharan region. So this is, I think, is impressed as a hallmark of like capacity building efforts. So this is the one really impressed and surprising issue. And to the first question, so we back to like 2015 or nearly that time is Dr. Godfrey Balabona joined us, and we initiated recruiting patient samples and looking at drug resistance mutations in reverse transcriptase regions. And the surprising issue is also many, like nearly 30% of like treatment naive patients show or having like drug resistance associated mutations. But not only that, what I surprised is very unique epidemic in Tanzania, because we saw like 30% of like subtype A and 30% subtype C and 10% subtype D. And mostly subtype C coming from South and subtype A and D coming from maybe central region of Africa. But the remaining 30% is like intersubtype recombinants. And really actively they're like making recombinants. And that is actually very unique profile of Tanzanian epidemic in HIV infection. So this is the reason we are also looking at like integrase lesion before integrase inhibitor is coming into this country. And we confirm very rarely finds like naturally occurring mutations in integrase lesion, especially in drug binding sites. And we are also right now we are also looking at capsid lesion of HIV gene because it's very effective, like new drugs. It's capsid inhibitor. It's coming into also our country, and also maybe will be in, I think, sub-Saharan countries in near future. So we are looking at like potential risk and also potentially safe of like drug resistance or potentially drug resistance, like acquiring mutations in predisposing like genotypes in Tanzanian epidemic. And also like as like Dr. Kamali told, like we are also looking, we really as an evidence of our experience is some of the mutations outside like pole lesion or gag lesion, like sometimes in envelope lesion, the virus gain like better fitness, and that result like eventually result in reduced sensitivity to antiretroviral drugs. So the resistance studies is becoming like complex. So it's not only drug binding sites, but also like some other the mutations in some other regions, like eventually result in reduced sensitivity of the drug. And this is, I think, one like we're really overlooking these events. So therefore, we think is looking at the entire region of HIV is becoming very important. And recent like like next generation sequencing, like nanopore technology, can allow us to do that in not only in all not I don't mean in all the patients, but like looking at some of the patients, how like HIV, genetic, genotype in Tanzania is how they look like, and also how like difference in other regions or sub-Saharan Africa or other regions in the world. So these are the answer to the first question. And the second question, answer to the second question is, I think it's public health approach, like treat all policy. It's so far works very effective. And as Dr. Kamali told, like 90% of treated people suppress HIV viremia. So it means it's, as a researcher, we just take a look at only 5% population. So 95% is successful. We do not need to take care of these people. Public health approach is successful. Only what is we are looking at 5% of population. And one like strategy is we'd like to break down what kind of people in 5%. And one issue we recently implemented is children. So children it's from 0 to 40 years old. So it's really huge differences. So, but actually children do not show such effective, like for example, 90% of children do not show like viral suppression. Is much worse. So I think it's, like breaking down failure population and look at what causes the failure is one like hint to look at like increase like effectiveness. And one is because of the size of the bodies or huge differences in size of the bodies in each children. And also like maybe adherence. And in some, the point is, I think it's drug concentration in the body. And if the drug concentration do not go to like effective concentration, I think that is very much functional, like for allow the virus to acquire resistance mutations. It's really a good condition for virus to escape. So therefore, I think is looking first at children and how we can increase effectiveness. So maybe not necessarily individual children, but like looking at what type of children, or maybe like babies or 5 years old or 10 years old. So these are, I think it's important. And also there, as time goes by, like children grow up and we are afraid of their a source of like spreading drug resistance mutations in this country to like not only to heterosexual transmission, but also going down to next generation babies. So this is my message.
Okay, thank you very much, Professor Ueno. Thank you very much. And thank you very much, panelists. In brief, ladies and gentlemen, the panelists have addressed a number of questions. The Ministry of Health has done quite a lot in terms of addressing the subject. A lot has been done in terms of viral load testing, doing HIV drug resistance surveys, and also surveillance. They're encountering a number of challenges, particularly clinicians are failing at times to identify or to detect resistance in the clinical setting. And what the ministry thinks is very important is to have laboratory-based approach in trying to confirm resistance. And this would appear to be a more preferable approach than the periodic surveys, for example, that are conducted, which perhaps are very expensive and maybe not very informative. However, also, the testing strategy, especially using genotyping, much as it is good for confirming resistance, is expensive. Joanne shared with us experience with DTG. It is a good drug. However, the challenge is the emerging resistance. And she thinks that it is very, very important to pay special attention to children and the adolescents in investigating their response to DTG treatment and ensure that strategies are put in place to promote anti-HIV drug resistance stewardship, and not just to limit it stewardship to antibacterial drug resistance. And then Professor Sangeda addressed the question put to him by emphasizing on the need for addressing adherence and stigma. Very, very important for all strategies that we are undertaking to prevent antiretroviral drug resistance. He mentioned that there are several new antiretrovirals that are under development. And in his view, he thinks that it is feasible to introduce the same in our population when appropriate time presents. And also, it is likely that they will be acceptable, especially if their efficacy is noted. And he also mentioned the need for introducing individual-based assessment in the course of treatment, and not to just rely on population-based approaches, which at times may leave behind some individuals who are not responding to antiretroviral drug resistance. And in general, monitoring adherence and surveillance should be of paramount importance. Finally, Professor Ueno shared with us, first of all, the experiences he has had with our Tanzanian colleagues who have been working in his laboratory. And these have been doing a lot of studies in looking at the mutations of antiretroviral drug resistance. Doreen was specifically mentioned because she has been working in the lab of Ueno since 2012. And in the view of her mentor, she's one of the experts to be depended on in this country. Dr. Barabona, I think I don't know if all of the people here know you. If you can stand up so that they know you. Dr. Barabona is also, yes, has done a lot of studies in gene mutation, in mutations, HIV mutations that are associated with the resistance. In brief, Professor Ueno is saying that those basic science-based studies are very, very important in studying the whole science of antiretroviral drug resistance and looking at regions that have not been investigated before in our setting. And they finally say that the public health approaches that have been undertaken, for example, the treat all approach is very important. However, looking at the small proportion and trying to investigate the salient factors that are responsible for emerging resistance in such a population is also very important, and it will give us a lot of information. And he has a feeling that focusing on children in particular will give us very informative results that can inform our anti-HIV drug resistance prevention in the country. So now, ladies and gentlemen, with that very brief summary, I invite questions from the audience, please. In the interest of time, be very brief and focused.
Thank you, Professor Lyamuya. My name is Redempta Mbatia. I'm working with an implementing partner, and I appreciate being part of and parcel of this symposium because we are now bringing programming and research together to benefit humanity. So thank you. And I appreciate also the keynote speaker. I have two quick questions. The first one is literature shows that adherence, yes, we know adherence is an issue, but literature shows that adherence here in Tanzania, I can speak of in Tanzania, is actually much better compared to countries which are developed like America. Now, can we also get some idea of how the drug resistant situation is there compared to ours? So that is the first one. And the second question is, I think this goes mainly to Dr. Venner, but also with all the experts who have influence on the policymakers. Do they really understand such issues? You know, can we, because when you talk about doing genotyping, even among the 90-something who are already on treatment and are not suppressing, that would be actually a smaller number. Have we been able to inform the politicians what it means, especially as we are talking about sustainability, where the funding for HIV programming will rely on domestic resources? Because I think resources is always an issue, and yes, we need to have increased lab capacity, but it all goes to resources and resource allocation. But how much have we engaged the politicians to really understand the science behind what is being said? Otherwise, I think we are really getting into the same old stories. Thank you.
Okay, thank you very much. Can I receive other few questions and then ask the panel to respond? Someone has a hand up. Okay.
Okay, thank you very much, audience. My name is Salome Magembe from Moi. I'm a research ethicist. I have one question. I was just asking myself, HIV patients are always acquired other diseases because of low immunity. And when they acquire these diseases, they used to use other antibiotics and other medications. Is there any relation with this adherence of DTG with this drug interaction of other diseases, of other medications? Is there any maybe reason of getting adherence of the resistance of this drug because of drug interaction?
Okay, thank you. Another question.
Good afternoon. My name is Shabani Kingazi. So my question is like a comment and something that maybe goes to the minister, NASHCOP. From my knowledge, I know that every situation or condition has what we call the key and vulnerable population. So as Professor finalized there that we have to find the people who are really affected by the situation. And throughout the presentation, we have seen that children and pediatric and adolescent particularly are really affected with this issue of drug resistance. But also there are other groups like those falling into the social and economical situation that affect them, making it difficult to take their drug properly. So we have been have a lot of program in this country supporting children. For example, you know, there are some organizations working on overseas to support the children. So my call here is for the ministry to take it seriously, so that when we are saying that we have the program real supporting the pediatrics and adolescents to make sure that they are taking medication, these programs are really monitored and they have what you call the impact linked to reduce the drug resistance issues among the pediatric and children. Thank you.
Okay, thank you. That was the third question. Any other burning one, the fourth one? Or there are several? But be very brief and focused when you ask.
Well, thank you. My name is Paul Kapkagina. I'm from Ocean Road Cancer Institute. So my question goes, it's not like a question, comment goes to Minister of Health. Like we need also to integrate cancer oncology services with HIV services. With regards to points one, increasing stewardship among clinicians working in oncology services, because you see, most cancer patients first has the acceptance of first the HIV itself is difficult, but also adding the acceptance of cancer again is really difficult. So we need, I think, to train these first call in oncology services to make sure that they do understand it clear and they can appropriate talk to the patient on the balance of those medications. The second one is and the police issues. The integration also should go beyond the police, the clinicians' educations, but also the policies. Up to now, we don't have, I don't think we do have a standard treatment for standard cancer treatments for HIV infections or HIV infection treatment guidelines for cancer, specifically for cancer patients. So I think the area of seeing also, maybe we can work on the research to see the drug interactions, because the CD4 cannot, we cannot rely on the CD4 count to measure the immunology, because you see in the cancer patient, not only the CD4 can be lowered with HIV drugs, maybe could be cancer drugs, chemotherapy, radiotherapy, or any medication that a patient is taking. Thank you so much.
Okay, thank you. I think that is largely a comment, and you are not expecting a response from the panel. Okay. Final question before I ask the.
Yes. Good evening. My name is Elia Daud, working with Implementing Partner. And also myself, I want just to ask how our data systems communicates in terms of HIV drug resistance. Do our data systems capturing information from the on-time field pickups, adherence, prescribing practices, and all up to HIV viral load? Do our data systems integrated in such a way that communicates all the processes to identify these clients falling into HIV drug resistance? Thank you.
Okay. Last one before.
Okay, thank you. My name's Eligius Wilbard Kitatwile. I'm the MUHAS student, a second year student here at MUHAS. I have a question, and my question is targeted to the representative from the Ministry of Health. My question is, what strategic initiatives do you believe are most critical and effective in monitoring and combating HIV drug resistance in Tanzania, particularly in rural areas as well as underserved areas in Tanzania? What are the strategic initiatives do you believe can help us to combat those drug resistance as prescribed? Thank you.
Okay, thank you. That was religious. We are very few in the world. So thank you very much. Let us hear from the panelists. I'll give a kind of bias to respond to the last question. Ministry of Health representative, please.
Thank you, audience, for such questions, and I'm keen to know more about what has been presented. The first one was from Dr. Redemptor regarding our wish to have genotyping as the standard of care. Yes, as the Ministry of Health, we know that this will help us a lot to do individualized treatment, just like what others in the West are doing. And yes, the cost is there, and we know that it will cost. But as I said, and as you may know, in most of the policies we are adopting in this country, we go for priority. We may not go into full scale. We may prioritize for those, let's say, children or any other people who are more vulnerable to HIV drug resistance. So that would be our approach, and that doesn't prevent us from doing costing and including it in our implementation plan. So we'll do it phase-wise and see how it goes. The second one, I think on KVP, especially children, we call this OVP, sorry. So we have OVC program. This was a kind of comment, and I would just like to emphasize that there's a regulation on how to monitor these programs. So if there's anything you see that the program isn't performing as it was supposed to, I think there are mechanisms to follow it up. And another comment was from Polycarp regarding NCD and HIV integration. We do have integration of at least some cancers into HIV. Just to mention a few, cervical cancer and Kaposi sarcoma management has been with HIV, and we have guidelines regarding that. So I think other HIV related malignancies are also included, like Hodgkin's and the like. So the same applies to the presence of policies in those integration. Then the other one on databases, we may not have a full-blown, like all the parameters which are needed to track or to monitor HIV drug resistance, but we do have some variables within our databases, like HVL results. There in our database, we do have adherence and counseling status. So we are tracking. We may not have all the variables which are needed, but we have a database, except results for the HIV drug resistance mutation is not integrated into the national HIV database. And the last was from my colleague who is a student within MUHAS, strategy which is fitting within the rural areas. I think there are no like segregation between rural and urban, but to insist without thinking of state-of-the-art monitoring strategies, there are very low-hanging strategies which could be implemented, like the clinical acumen for clinicians. These are things which can be followed up by every one of us who are seeing patients, and we can achieve HIV drug resistance prevention. So thank you very much and welcome again. Thank you, moderator.
Okay, thank you very much. There was another question on the interaction of ARV drugs, the drugs that are used for the treatment of opportunistic infections. I think, Joanne, you are better placed to respond to this.
Yes, Professor. Thank you. Thank you, my sister from, I think, Moi. And there was another question again in the same line with adherence. But beginning with these core medications. So as it's kind of a wide scope when we spoke of quality of care, because all these are stipulated in our guidelines. Some of the facilities, they have job aids to pinpoint the key areas or the key issues that a clinician should be watchful. That is one of the things that they need to look at, drug-drug interactions. So any other disease which is supposed to be treated, be it co-infections like tuberculosis, cryptococcus infection or disease, it needs to be aligned with what will match with the ART vis-a-vis the co-medications. We have even other drugs of some NCDs, diabetes, we have metformin, we can mention many of them. But the key point I want to emphasize is that we need clinicians to be knowledgeable, but also to have job aids, we call them job aids, to assist them. For the ones who are either new to the field, they will look at the job aids. It will highlight the key areas to be watchful, what not to co-administer, or there is a dose adjustments or substitution of ARTs or ARVs when it comes to co-infections. But I just wanted to mention briefly about the issue of adherence and why we have drug-resistant mutations. Much as DTG has been always known as a drug forgiving, it forgives adherence. So a client might skip
some of the, the doses in a day or weeks, that is allowed or that is favored by DTG, but that is short term. We need long-term adherence for a combination of ART to be effective. Remember, it's not only DTG monotherapy, we are combining it with an NRTI backbone. So we need adherence for all 2 to 3 effective drugs to be effective. We need adherence for all. Now we have fixed those combinations. We have tenofovir, lamivudine, dolutegravir. You can't separate them, but I'm adhering to dolutegravir only, and I leave out lamivudine or the other one. So that one also is an area that might be able to be explaining why we have drug resistance to some of the drugs. Thank you.
Okay, thank you very much. We have people who are online also, and there are 2 questions they have posed. The first one goes to any of the panelists, and it is asks, do we think pill count is a satisfactory measure of antiretroviral therapy adherence? Or is there a room to think of other ways of assessing ART adherence? That was one of the questions. And then the other one is DTG resistance linked to PrEP and PEP, that is pre-exposure prophylaxis and post-exposure prophylaxis programs? There are some additional ones also from the online participants. The other question is, we don't have DTG regimen for children below 3 kilograms, and we use AZT, 3TC, and NVP. Though these kids are few. NVP and other NNRTIs were declared as ineffective. Other countries are using RAL. What could be your recommendation? I don't know what the RAL stands for. Okay, okay. And the other question from the online viewers, there are also other laboratories within the country with the capacity of preparing HIV or of performing HIV drug resistance testing, such as the Ifakara Health Institute Laboratory in Bagamoyo. Does the ministry have plans of utilizing the lab from research and teaching institutions to improve our HIV drug resistance testing capacity? Those were the additional questions from the online viewers. I ask you to respond on any of those.
Okay.
Adherence, I think it is Professor Sangela.
Thank you, Prof. So thank you to the online participant for the question about whether we should rely on pill count or not. Before I go to that question, but I would also like to address a bit what Dr. Redemptor also asked with regard to comparisons from America and Africa, also on the same issue of adherence. She asked why, if people in Africa are more compliant, more adherent to antiretroviral therapy, why is it then they have high drug resistance? So it requires a study, but we can only predict or hypothesize that people in America, they use individualized treatment, which is mostly guided by genotyping. And they do this on routine basis. It's just incorporated within the routine care. So they will detect very early if there are any signs of emergence of HIV drug resistance and intervene. Additionally, they have a wide array of choices of what kind of treatment they can do, which can be also guided by that genotyping. Whereas we have very limited options. Even sometimes you see a mutation And the only available option is also the mutation that developed in previous regimen also will apply to the regimen that you have on your table. And this can account for these problems. So we don't have active monitoring, and if a patient is missed by the clinician, they are not taken to second line, then they are extended for another year before we know that these patients are failing, and the mutations will have accumulated. In fact, some data show that even though the Western countries started the treatment earlier than us, which would expect that they have high HIV drug resistance, in the contrary, the countries which came up later in the scale up of antiretroviral are the ones that have more problems, and East Africa is one of them. A study on transmitted drug resistance showed that East Africa, followed by Southern Africa countries, have more transmitted drug resistance, and I think that's what I can hypothesize on that. With regard to the pill count, indeed, as it was mentioned by Dr. Wena, you cannot rely on pill count for many reasons. Our patients are much smarter, they know our systems. So the patient can borrow pills from their relative, and they can show them in front of the clinician to say that they are adherent. Secondly, as it was also proposed, we need to change our tools. The tool just asks you, are you adherent or not adherent? If you ask me and you are my clinician, I will definitely tell you I take my medications even if I don't. So some of the adherence measurement methods are very subjective. We need objective measurements. Monitoring concentration of the drug in the body, was said by Professor Weno here, would be an ideal approach, but it will be limited by resources unless we sort out those people who are in high need, like the 5% or the smaller percent of patients who have much problem. We sort them out and we try to monitor those. So other methods would be pharmacy refill. And here, there was a question about data integrity. And Dr. Wena has a rich database, which some time ago I have had an access to it. And we sampled, for example, about 40,000 patients, and we are able to analyze from those parameters. If you look at the appointments of those patients, then you can determine refill levels. So if a patient has an appointment on a particular date, and they come 5 days later than that date, you can calculate there what is the pharmacy refill, how long they've gone without pills. And we have validated this before using viral load, and also using some forest-free algorithms to try to validate if this approach is good, and it seems to be real good. So maybe this is an approach we can talk with the ministry, because this is data that is available for free. I mean, not for free, but it's there, just sitting, waiting to be used. Then you can identify people who have serious issues. For example, if I look at the patterns, if I categorize them by age, what I see is a group of people between what we call adolescents. I think that group, if you look at the percentage of non-adherence, it really peaks, especially the school-going kids, up to some place where they're in university, I think. And then when they become adults with responsibilities with children, you can see it going down. And then when they are really aged, I think because of some age issues, then you have some peaks up and down. So age, I think, can be one of the factors that can really, with using the pharmacy refill. Of course, viral load is classic, and genotype would have been the best. But depending on resources, I see pharmacy refill as one of the cheap alternatives that we can easily use to measure this kind of progression. Thank you.
Okay, thank you, Prof. The Minister of Health, please, can you respond to the question on, does the ministry have plans of utilizing laboratories like the one at Ifakara and elsewhere in teaching and research institutions in order to improve HIV drug-resistant testing capacity in the country?
Thank you very much, Prof. Yes, we very much welcome such an arrangement. As I said, we are expanding, and it's our wish to expand the genotyping service So we do welcome private entities to work with the Ministry of Health through PPP, the private public partnership. So that is more than welcome. Thank you.
Okay, there was also an outcry about lack of DTG-like regimen among children. So what is the response?
Yeah, it's not lack as such, but children below 3 kgs are not eligible for DTG, so they have another regimen. So the guy was asking the possibility of giving them raltegravir, which is one of the options for children below 3 kgs. And we, as a country, we are working on registering raltegravir in country.
So it is under processing?
Yes.
Okay. There was also another question on whether there was a link between DTG resistance and pre-exposure prophylaxis and post-exposure prophylaxis programs.
Yeah, thank you, Prof. So for the pre-exposure, we use Truvada, that's TDF and emtricitabine, and we don't use dolutegravir. But for the post-exposure prophylaxis, that's when we use TLD. We use the default dolutegravir. So we have not really had data to explain that the post-exposure prophylaxis now has developed resistance. But with pre-exposure, we don't expect, as I've explained, because we use a different drug for pre-exposure prophylaxis. Thank you.
Okay, thank you very much. Ladies and gentlemen, I think we are about to close. If there is any burning comment, especially from the management, I don't know if there is any burning. Okay, that should be the last one. And please make it short and very focused.
Thank you. Thank you very much, presenters and the dignitaries at the front. My question is simple and straight. Sorry, I'm a bit traditionalist and just have to know whether we have some traditional medicine in treating HIV/AIDS and also on whether they develop such resistance. Thank you very much.
Okay, thank you very much. Any one of you, please.
Thank you very much. Thank you for the question. As far as I know, we haven't certified any medication for HIV treatment as such. That's from me, probably from other panelists, if they know any, that it cures or at least it suppresses HIV viral load. I'm not aware of. Thank you.
Okay, you know, I started my medical training in 1980, and that was about the time when HIV emerged in the world. So for those close to 44 years, I've never heard of alternative treatment for HIV that comes from the traditional arena. So that is what I can say. However, we would very much appreciate having a drug from that source, which is efficacious, has no side effects, and is good. It will be very good. Okay, so ladies and gentlemen, we have come to the end of our panel discussion. I would like to request you to join me to give a clap to the panelists. Thank you very much for your responses and for your discussion, which has been very, very resourceful. And ladies and gentlemen, I thank you very much for your cooperation, your attention, and you are being very active throughout the process. Thank you.
Thank you very much. Our chairperson has asked us to clap for the panelists, but we have not clapped for our chairperson. Can we put our hands together for him? He has done a wonderful job, and we truly thank you for that. Ladies and gentlemen, we apologize that we have run a little bit late, but I think you will agree with me that it was very interesting. We didn't even see the time. Now we have come almost to the end of the closing of this symposium. I would like to ask the high table, the one that were on the high table, to come back again so that we can close properly. The guest of honor, our guest of honor, the DVCs, the VC, the keynote speaker, and the DRC, the DVCRC. Thank you very much. Before I welcome the acting Deputy Vice Chancellor, Research and Consultants to come and say a few words and close the symposium, we have a small token, an award of recognition to Professor Ueno. And as MUHAS, we want to recognize his contribution to the research and PhD and PhD training and capacity building in the field of HIV to MUHAS. If you look at the biography, you will see how much he has done this in Tanzania and to MUHAS. And today we want to give him just a recognition, a token of recognition. I would like to ask the high table to stand up, and the guest of honor will give it to you. Karibu, you can come forward so that you can receive this recognition. Yes, that is a small award of recognition and certificate, just to recognize and appreciate for your contribution to MUHAS on this field. Thank you very much. We can do much better. He has done a lot, so we can do much better. We can clap some more. Asante sana. So we can take our seats. Thank you, Professor Ueno. Now I would like to welcome the acting Deputy Vice Chancellor, Research and Consultants, Dr. Naiha, to come and say some few words and close this symposium. Karibu sana.
Thank you, everyone, for your patience and your time. I would not like to use more of your time this afternoon. A vote of thanks to our guest of honor, Director General, National Institute of Medical Research, NIMRI, Professor Said Aboud, our Deputy Vice Chancellor, our acting Vice Chancellor, Professor Balandia, but also Deputy Vice Chancellor, Planning, Finance and Administration, our Professor Erasto Mbugi, government officials who are present in the room, other program implementing partners, distinguished guests, and collaborators from Kumamoto University, MUHAS colleague, academicians, scientists, MUHAS students, representatives from the media, other distinguished delegates, ladies and gentlemen, the keynote speaker, Dr. Doreen Kamori, thank you so much. We have learned a lot today, this afternoon. And on behalf of university, I would like to say thank you for your participation and time to discuss this important matter, specifically for the strategies and policy and guideline planning on the way forward on how to tackle HIV drug resistance in Tanzania. I think this was the right call to initiate the movement and discussions with the forum of academia, policymakers, and research collaborators. Through this, we hope that with a multi-sectoral approach, we will come up with innovations and strategic research areas where we can do more to support our public health. The data are alarming, increase of virological failures from almost 15% to almost 33%. This is alarming in 2021, and we need to do something. And just in a nutshell, I would really like to approve the last conclusion with Dr. Doreen from the statement of Dr. Meg Doherty, the director of WHO Department, Global HIV, quality HIV care delivery. So it's always quality of HIV delivery in all preventive areas, primary, secondary, tertiary. And this also, I think, reflects where we are sitting, whether clinical research innovation or any policy makers, strategic program implementers, it's quality of HIV care. So everyone, I think, has a responsibility to do better where we work, because it's always us to make a change. And it starts with us to make a change, whether in adherence, helping children count their pill, helping parents to adhere to the children's medications, or anything else related to that, reflects the quality of care we are providing to our community. And at this note, I would not add anything else. I think the message is out there. You can always refer to the media. You can get the retrieval of the discussion to refresh ourselves. And I would like to say or declare that the 11th MUHAS University-wide Research Symposium is officially closed. And we would really love to welcome you to our next 12 symposium. Please keep in touch, eyes open to our media platform, any other e-media platform related to MUHAS, and do not plan to miss this. Just in terms of coverage summary, today we had a pleasure to host almost 136 face-to-face physical participants, 38 in the Zoom, 16 in the YouTube, 6 media forum coverage, almost 200 participation in total. Karibuni sana. We look forward to host you to the next symposium.
Thank you. I'm not supposed to say anything after he has closed, but I will have to release our guest of honor. So we can all stand as our guest of honor is leaving. And thank him for staying until the end. Thank you very much for staying until the end of the symposium. Asante sana.